I'll be taking a class on fibrinolytics. So I'll just share the screen. Can you see the slides?
Yes, ma'am.
Yes. Adira, your connection is very poor. Okay, no problem. Anyway, I can hear you. Okay. So today's topic, it is fibrinolytics. So already you have studied how clot formation, blood clots that are formed in the body. And this already you have studied, but we will just have a look. See, for the coagulation pathway, there is an intrinsic pathway as well as an extrinsic pathway. Whenever some injury occurs externally or internally, any pathway, either intrinsic pathway or extrinsic pathway, it will be activated. So you know all these steps. So first 12, it will be converted to 12A. Then 12A will act on 11 to 11A, then 9 to 9A, then to 10 to 10A, and 10A will convert prothrombin to thrombin. That is why intrinsic pathway. Extrinsic, it is 7 to 7A, and again it will come. So here it is a combined pathway, 10 to 10A, and converting prothrombin to thrombin. So whenever a hemostatic plug formed, it is actually reinforced by, there is thrombin converting fibrinogen to fibrin. So it is reinforced by this fibrin and a thrombus is formed or a clot is formed. So that is whenever some injury occurs. So once the repair is over, so the clot formation, it is over, the function is over. So these are the pictures of this one. So here there's a normal, and this is the blood clot formation, and once it is dislodged, it is called an embolus also. Everything you know. Then so I was telling, once the repair is over, now the fibrinolytic system, it will be activated. So we cannot keep the full vessel, it is clogged with clots, etc. So there will be fibrinolysis. So for fibrinolysis, one serine protease, this is the plasmin, is the main factor. And this plasmin, it is produced from plasminogen. And this plasminogen, it is circulating in the blood as well as it is attached to fibrin or the tissue also. And there is a factor called tissue plasminogen activator that is obtained from, that is liberated or released from the endothelial cells, that is at the site of injury or at the site of clot formation. And so this tissue plasminogen activator, it will convert plasminogen to plasmin. So this plasmin is the one that will lyse the fibrin involved clots. So it will be converted to fibrin degradation products. So this is plasmin, that is the most important. So that is how once a clot is formed, after that, once the repair is over, this fibrinolytic system will come into action and everything will go like that. Otherwise, it will be a continuous process of clot formation. So it should not be allowed. So that is the thing. So plasmin comes into action and it will convert fibrin to fibrin degradation products. So now we will be seeing we are going to see fibrinolytics or thrombolytics that will lyse the thrombus or lyse fibrin. So the mechanism of action of the pharmacological drug, thrombolytic drugs or the fibrinolytic drugs, they are actually activators of plasminogen. Plasminogen activates, so that plasminogen is converted to plasmin, and this plasmin will degrade the fibrin to soluble degradation products. So this is the mechanism of action of all thrombolytic drugs. But this, okay, I'll come to the next slide. So this I have already told. Drugs used to lyse thrombi, they are called thrombolytic drugs. And if the thrombi is more than 3 days old, then the fibrinolytic drugs, it is having less effect. And also venous thrombi, it will be lysed more easily than the arterial thrombi. And this I have told already, an activator substance, tissue plasminogen activator of plasminogen activator present in tissues converts plasminogen to fibrinolytic plasmin, and this plasmin will break down the fibrin clots. But one problem is that it is non-specific in action, this plasmin, because it acts on the proteins as well as the, that is bound to the fibrin as well as other the circulating, this one also it is acting, so it is non-specific. So that is again I have written plasminogen, the inactive proteolytic enzyme plasma during the binds fibrin during the formation of a thrombus. The fibrin-bound plasminogen is more susceptible to the activation than the plasminogen in circulation. So that's what I was telling. This plasminogen, it is in the circulation as well as it is bound to fibrin also. So this tissue plasminogen activator, it is activating more this plasminogen that is bound to fibrin. But it can also act on plasminogen in circulation, but it is more to plasminogen that is bound to fibrin. And our this fibrinolytic agents, it will be, they are actually plasminogen activators. Again, we will be seeing again this. Okay, this fibrinolytic, so this is a double-edged weapon or double-edged sword. So that's what, these thrombolytic agents, they cannot distinguish between the fibrin of a thrombus and the fibrin of a hemostatic plug. That is the early drugs. There are some new drugs which are very specific for the fibrin of a thrombus. So we will be saying that in the beginning they were considered as double-edged weapons, but recently many drugs have been found out which will be specific for the fibrin of a thrombus. Okay. Now we will see. So there are two types of thrombolytic drugs, non-fibrin specific and fibrin specific. So these are the earlier drugs, that is streptokinase, anistreptylase, urokinase. These three are non-fibrin specific. Whereas fibrin specific, that is tissue plasminogen activators, they are alteplase, reteplase and tenecteplase. This is the most important drug. So thus two groups of drugs, that is non-fibrin specific and fibrin specific. So we will see one by one. We will first see streptokinase. Streptokinase, it is actually obtained from the beta hemolytic streptococci group C. So, and it is, I have told it is non-fibrin specific. So it will be activating both the circulating as well as fibrin bound plasminogen. And the action is, it will be depleting the circulating fibrinogen, but you can see when it is lysed, there will be bleeding. So all thrombolytic drugs, it can, as a side effect, it can cause bleeding also. So we have to control, okay, we will see that. And but this streptokinase, this was the very commonly used drug years back, but now it is new, since newer drugs have come, its use have been has been reduced, because it reduces, there is less reduction in the myocardial infarction related mortality. So this thrombosis, usually we use this drugs in mainly in myocardial infarction. That is, there only the thrombus formation and the clot formation and ischemia, infarction, etc. So this streptokinase, there is less reduction in the myocardial infarction related mortality. And another thing, it also needs a loading dose. Because there is this, it is obtained from beta hemolytic streptococci, there will be anti-streptococcal antibodies are will be formed. Because of that, we need a loading dose also. Now, which are the adverse effects? Hypersensitivity reactions can occur. So this again, and it cannot be used for second time because of the neutralization by antibodies. So we have to wait for some time, then only we can use. If so this month one person is developing myocardial infarction and we have used this drug, so immediately another second month again, second attack, again we cannot use that, we have to wait, because it is neutralization by antibodies will be there, so it may not be effective. Then other adverse reactions are fever can occur, hypotension, arrhythmia can occur. Then because all these drugs, it can cause bleeding. So if there is a person is having an unsuspected peptic ulcer, so when this injection is given, then from the stomach, from the duodenum, the bleeding can occur because of the action. Then, but this is the least expensive thrombolytic drug, that is the streptokinase. Then another acylated plasminogen streptokinase activator complex, that is called anistreptylase. This name you can see, there is another drug called anistreptylase. Okay, so that was about streptokinase. Now, second drug, that is the urokinase. These are all non-fibrin specific. So this is actually isolated from, so the name itself, it is urokinase. So it is obtained from, it is developed from human urine. Now, for the commercial purpose, it is cultured human kidney cells, it is developed. But this also, its use has gone out because of the other, it is non-fibrin specific because of that. Then, but there is a recombinant pro-urokinase. This is specific to this fibrin. So it is used, but even then other better drugs are there, so we are not using much this urokinase, but this is a cheaper one, urokinase. Yes, it is not antigenic, not pyrogenic, and does not cause allergic reaction, lacks fibrin specificity, no, it is not much expensive, it is something, it is not that. Okay, so, but compared to streptokinase, it is expensive. So, okay, it is non-antigenic. So, streptokinase was antigenic. This is not antigenic, non-pyrogenic, and does not cause allergic reaction. But it is non-fibrin specific or lacks fibrin specificity. Okay, so that is urokinase. Then altiplase. Altiplase, it is the recombinant tissue type plasminogen activator. So it is better drug, isn't it? Altiplase. It is this tissue type plasminogen activator. So it is more fibrin specific, and it is obtained by the recombinant DNA technology, and moderately specific compared to streptokinase and other urokinase, specific for fibrin bound plasminogen, because we need thrombolytics which are specific for fibrin bound plasminogen. So the plasminogen that is attached to the fibrin, it should be activated so that the plasmin will be formed, and that will lyse the fibrin clot. So here this altiplase, it is more specific compared to streptokinase, it is more specific. Then this altiplase, it is having a T-half of 4 to 8 minutes. Because it is very short T-half, we have to give IV infusion. And all these thrombolytic drugs, even though it causes the thrombolysis, we have to add some and anticoagulants like heparin, aspirin, antiplatelet, etc. should be added. That you will study again later. So when you study anticoagulants, this will be dealt in detail. This is to prevent rethrombosis. We will be adding, or this extension of the thrombosis, we will be adding anticoagulant like heparin and antiplatelet like aspirin also. Then all this, the risk of bleeding, it is there with all thrombolytic agents, and also altiplase also, it is a recombinant DNA technology, so it is not non-antigenic, but mild hypertension, fever, but it is expensive. So that is altiplase. Now this is retiplase. Retiplase. So here this retiplase, actually it is a mutant of this the RTPA. So it is again produced by recombinant DNA technology. Mutant means some amino acids of the native tissue plasminogen activator, it will be missing. So again, compared to others, it is selective, but less selective for fibrin bound plasminogen. So, but the most selective, I am telling the next drug, that is, and another thing, retiplase, it is having a longer duration also. So this is the one which is the most important and higher fibrin selectivity is there. So that is tenecteplase. It is again obtained by genetically engineered substitution mutant of native tissue plasminogen activator. So it is the genetically engineered method. That is tenecteplase. It is the high fibrin selectivity and slower plasma clearance. That means it is, so clearance will be slow. That means longer duration of action. Tenecteplase, and it is the only fibrinolytic agent that can be injected IV as a single bolus dose over 10 seconds. So we can just push the drug. So this is the only fibrinolytic or thrombolytic agent that can be injected IV. So this altiplase, you can see altiplase requires 90 minutes infusion because of the short T-half, and retiplase needs 2 injections at 30 minutes interval. So, but this can be injected IV as a single bolus. Bolus means at a stretch we can inject over 10 seconds. So because of this, suppose a patient is developing heart attack or myocardial infarction that is at home, and he has to be taken to the hospital. So in the ambulance itself, we can give this fibrinolytic agent. So, and this, so that is what it's written. This feature makes it possible to institute fibrinolytic therapy immediately on diagnosis of STMA, even during the transport of the patient to the hospital. So this is that is the tenecteplase. So this is a high fibrin selective thrombolytic agent, and it is also resistant to inhibition by this plasminogen activator inhibitor 1. So it is not inhibited also. So it is one of the important drug, tenecteplase. So we have seen that altiplase, retiplase, and tenecteplase are fibrin specific, whereas non-fibrin specific, it is fibrin non-specific, it is streptokinase, anistreptylase, and urokinase. Now we will see the uses of fibrinolytics. So we have already seen it is used in acute myocardial infarction, but it is useful only for ST segment elevation myocardial. The STEMI means ST segment elevation myocardial infarction. And this fibrinolytic these drugs, they are the first line approach for the emergent in the case of this STMA, that is ST elevation myocardial infarction. So you would have heard of this percutaneous coronary intervention. Hello, have you heard of that? Whom should I ask? Adira, have you heard of this percutaneous intervention?
Ma'am?
Have you heard of such procedure like percutaneous coronary intervention with stent replacement?
No, ma'am.
Have you heard of angioplasty?
Yes, ma'am.
It is the same thing. So it is the another word, PCI, percutaneous coronary intervention with stent replacement. So this actually, this causes the recanalization of the thrombosed coronary artery in 50 to 90% cases. So I was telling, we are having drugs like thrombolytic drugs. So we are comparing thrombolytic drugs with PCA. PCA is an intervention, isn't it? It is not a drug, it is a mechanism or technique. So like this is the angioplasty. So here we can see there is a block. So this angioplasty catheter or the wire, it will be inserted, and it will be, this is the balloon. So this will be expanded so that we are actually increasing the size of the lumen. So it is pressed like that. So the blood flow will be made easier. So this is what is happening in angioplasty. So I was telling, we can use fibrinolytics in the STEMI, or we can use angioplasty. And STEMI, it is the best, it is a chief indication for STEMI, but if you can do PC, that is okay. Otherwise, we can use this fibrinolytics. But only thing, the fibrinolytics should be given, if infarction occurs, it should be given within an hour, that is the golden hour. It is the golden hour. And after if 3 hours it is over, means don't give any thrombolytic drugs. going for this PCA, because this is just a picture of endocardium as well as epicardium. So if once the thrombus formation occurs from the subendocardium, this ischemia or the thrombus formation or the infarction, it will be it may travel or it may extend up to this epicardium. So this from subendocardium to epicardium, this takes around 6 hours. So once it is reaching here, then if you are giving thrombolytics, already some damage has occurred. So it won't be that much effective. So the first hour, it is the golden hour. In the golden hour itself, you should do something thrombolytic therapy we have to do. Then only we can save the myocardium. So that is the thing. So thrombolytics we have to do within an hour or maximum 6 hours. After 6 hours, it is of no use, and it better after 3 hours going for this PCA, that is percutaneous coronary intervention, so that we can. And another thing, if you are using PCA, there won't be any bleeding also, because all these thrombolytic drugs, it can cause, fibrinolytic drugs can cause bleeding. Yes, PCA has the, yes, what I was telling, it has the lower bleeding risk, higher grade of flow in the canalized artery, and reduction in the rate of non-fatal recurrent MI compared to thrombolysis. Thrombolysis also, it will reduce the recurrence of myocardial infarction, but compared to PCA, there is less. Yes, but if the patients there is some contraindication for, we will be seeing the contraindications. If there is a contraindication, we have to go for PCA. Then and fibrinolytic. Then another one is facilitated PCA. Facilitated PCA means we will be giving fibrinolytic therapy and followed by this immediately. So suppose if there is the MI occurred and it is 5 hours, so immediately you give a thrombolysis and after that you insert this PCA, so that we are getting the benefit of both. So this is called a facilitated PCA. So first we will be giving thrombolysis, then followed by PCA. And most of the cases, we will be giving aspirin and heparin also. This is to prevent rethrombosis. Yes. So we were seeing the use of fibrinolytics in myocardial infarction. So I have seen everything. We have seen everything. Then second use is deep vein thrombosis. Usually it can occur in leg, pelvis, or shoulder. And this will, if you are using thrombolysis, thrombolytic drugs, it will preservation of venous valve and the risk of pulmonary embolism. Pulmonary embolism occurs by the dislodgement of the thrombus, that can be prevented. But usually for deep vein thrombosis, we will give anticoagulants, because both are having risk of hemorrhage, but usually anticoagulants are used. Then pulmonary embolism, again the anticoagulant heparin is the mainstay, but we can use thrombolytic drugs. Then peripheral arterial occlusion, again, if there is some occlusion in the artery, we can give by systemic therapy or intra-arterial injection directly into the artery where the occlusion is there, that we can do. So pulmonary embolism. So first one was MI, deep vein thrombosis, pulmonary embolism, peripheral arterial occlusion. Another thing we can use for stroke. But before giving for stroke, we have to do the MRI and see that there is a clot. If it is a hemorrhage, a stroke, if it is due to hemorrhage, we cannot use that. It is contraindicated. Altiplase is the drug that is used for ischemic stroke. Okay, these are the contraindications. So this is actually I don't have to describe, because you know that all these thrombolytic drugs, it causes bleeding. So any condition, if there is which is causing bleeding, such conditions we cannot give thrombolytic therapy. So if there is intracranial hemorrhage, we cannot use. Ischemic stroke in the past 3 months, mainly because of the hemorrhage, head injury. Okay. Intracranial tumor or vascular abnormality like aneurysm. Aneurysm, you know, there is a weak blood vessels. There will be it will be bulging like that. Finally, it may rupture. So that is called aneurysm. Then active bleeding disorders. Patients receiving anticoagulants. Peptic ulcer, esophageal varices. If it's already there, we cannot use. Then any wound or recent fracture or tooth extraction, we cannot use. So when, okay, I will complete this and I'll tell. Then history of major surgery within 3 weeks, because from the surgical site, it may bleed because if it is not healed properly. Then uncontrolled hypertension and pregnancy. This is the esophageal varices. Then, so when a patient is admitted in the, it's brought to ICU or the casualty and you are going to start thrombolysis, then you have to find out all this from the history. You have to rule out all these things. Otherwise, the patient may die of bleeding. So bleeding in the brain or somewhere in the stomach bleeding because of peptic ulcer. So all this, so before starting thrombolysis, we have to take the history and find out whether all these contraindications are there or not. If it is there, you should not. Going for PCA. Now, adverse reactions, again, it is self-explanatory. It can cause, all these thrombolytic drugs can cause bleeding. And it should be, if it is there, we have to give fresh frozen plasma. Then there may be microemboli can occur because we were using fibrinolytics and it will be lysing the thrombus. Sometimes there will be disintegration, that is spilling of the thrombus as microemboli. So that may be there. Then allergic reactions like streptokinase, hypotension can occur, hemorrhagic stroke because of the hemorrhage. And also during this thrombolytic therapy, we should not give any intramuscular injection because when we are giving intramuscular injection, we are making an injury, isn't it? So micro vessels, capillaries, etc., will be injured. So from there, bleeding can occur. So intramuscular injections are contraindicated during thrombolytic therapy. Then rethrombosis of veins, because when we are giving this thrombolysis, sometimes there may not be complete lysis, there may be incomplete lysis. So such cases, so usually in all cases, we will be giving heparin followed by this thrombolytic therapy. First day we will be giving thrombolysis, the second day onwards, they will be giving heparin. This is to prevent this rethrombosis of the veins. Heparin, it is an anticoagulant. Okay, that was all about fibrinolytic therapy.